So it's now my great pleasure to introduce to you Brian Rahmer. Karen already told you he really is at the intersection of health and housing. He's the Vice President of Health and Housing at Enterprise Community Partners, and I see him there. Please join me in welcoming Brian to the stage.
So good morning, everybody. It's my pleasure to be here. I want to thank the foundation, Karen and her team for always putting on a wonderful symposium. But today's special, not just because obviously we're talking about housing, but more importantly, because I think reflecting on Alan's last few comments, it gives us an opportunity to reset, re-engage, and understand sort of a historicity and a temporality of expectations that we don't always see in the context of the healthcare sector. Just to level set, how many folks work for health systems or hospitals in the crowd today? Okay, any folks working for insurers, managed care organizations, public health folks, identify? Housers, community development, excellent, that's wonderful. So I live I was born in Delaware, where the highest point in that state is just under 800 feet. So, it's always a pleasure to come to Colorado for a number of reasons. The people, obviously, the work that you all do, but the natural aspect of this is something that really hits home to me. And I had the privilege of taking a road trip with my family, 3 young kids and my wonderful wife, and spent some time in Colorado, went out to the Grand Canyon and so forth. And there's something about being around immense things that were not built by man that is just, grounding. It brings some clarity to the incredibly difficult work that all of us, you guys, do on a day-to-day basis. And I just want to thank you for you guys doing that work and for, the wonderful partnerships that Enterprise has been able to cultivate in Colorado. Denver Housing Authority, the city, the county, Habitat for Humanity, a number of hospital systems and payers. Those relationships are growing, and hopefully from our conversation today, we'll cultivate new ones as well. I want to thank and recognize our Enterprise staff that are here today, Katie, Jenny, Brittany, there may be others as well, and the folks listening on live stream. I want to reflect on Alan's comments around why, the why and the sort of how the healthcare sector has become interested and is engaging in the housing sector, the idea of social determinants of health being important to the healthcare sector, the concerns that Alan raised. These are important concerns for a number of reasons, but I think the last 2 points that he touched on, the first point being, when we look at housing, it forces us to look to the past. It forces us to recognize the entrenched, the insidious, the racist policies that created the disparities, the inequities, the inequalities in both wealth and asset accumulation, as Alan mentioned. But also this, what might be phrased or termed as our ability to control our own destiny. And this, to me, is a fundamental, inherent social determinant of health that is intimately tied to housing and the ability for us to have that safety, that security, that knowing, that understanding that we heard reflected in the videos earlier this morning of being able to come home, being able to feel like there's a place, there are people, there is a community that has your back, that will look out for you, that you can rely on. These are things that are incredibly important, not just because they are tied in many different ways along the causal pathway, so to speak, to mental health and well-being, our ability to sort of deal with issues of despair, our ability to handle adversity as it's being placed in front of us, and more importantly, our ability to recognize that we are not in this alone, and that the health, of my health is intimately tied to your health and well-being, and vice versa. And this to me, for lack of, for the risk of sounding sort of, out there a little bit, is probably the single most important element of value that the health care sector getting involved and engaged in the housing sector can bring to what we might consider population health improvement, community health improvement, or whatever. And the reason I say that is because what we're seeing today in the healthcare sector, and in terms of engagement, it does reflect what Alan mentioned earlier. It's sort of a population health perspective. These are the patients or panels of individuals that I'm managing or that I am at risk for, and that risk is tied to different payment reform efforts or payment reform models that either penalize or reward you for meeting certain quality outcomes. And what I'm seeing in the work that we're doing, and many folks in this room and across the country are doing in this space, I think is starting to inherently recognize that not only is that not enough, but if we continue to only focus on that in the midst of a broader context of, for instance, 3 consecutive, now going on 4 years of declining collective life expectancy in the United States of America, the richest nation that this country has ever witnessed in the history of the world. 3 consecutive years of declining life expectancy. We're seeing immense and growing physician and healthcare provider burnout, issues that are associated with substance abuse, drug use, despair in the general population as well, suicide. This is not evidence of a healthy society. This is certainly evidence of a sick society. And when we think about the context of housing and the inequities that are associated with wealth disparities in this country, which we're going to hear a lot about in the session following this one, I reflect on a statement, a quote that somebody who I admire, Vicente Navarro, who's a professor at Johns Hopkins University Bloomberg School of Public Health, and also in the University of Madrid in Spain. He says that it is not inequalities that kill, okay? It's those who benefit from those inequalities that kill. And when we consider this, particularly in the context of housing and its relationship to health, we have to recognize a couple of things. We heard Karen describing this, in her journey with her husband to buy a house, here. But more importantly, we see this play out across the board where we have many folks advocating for, denser housing, changes in zoning restrictions, the ability to build non-single family unit housing in communities and so on and so forth. And then when it comes time to pass the bond measure or, get the county council to sign off on that or go through the comprehensive zoning or planning process, a lot of people are quiet and they don't affirmatively vote for that kind of process. Most of the people who are benefiting from these inequities that are driving the kind of segregation by income that we're witnessing not only in the housing sector, but it has now spilled over and is continuing to spill over into the healthcare sector, where, as Alan mentioned, costs continue to increase. Even those with good, quote unquote, good employer-sponsored health insurance. I don't know how many of you have been looking at this over the course of your careers, but we feel it in our paychecks. Deductibles go up, premiums go up, and so on and so forth. So we are already, as a nation, rationing quality and access to that control over your own destiny. We're rationing it by income and by wealth and our ability to pay for it. So when we have conversations around things like our collective well-being, better being served by a systems change, like, universal comprehensive single-payer healthcare, for instance, we get this feedback that says, well, that's rationing, it's socialism, it's rationing. We are already doing that today. The late Huey Reinhardt mentioned this, and he's got a new book that just came out, health economist who worked at Princeton for many years, builds on sort of the godfather of health economics, Ken Arrow, a paper that was published in Health Affairs in 1963, that called this out in the sense that there are many other factors, including housing, that's explicitly stated there, that contribute to health and well-being beyond just the provision of health care, and that those things should be considered in the way that we understand how both we pay for healthcare delivery as well as how we value the contributors to long-term health and well-being. At Enterprise, we recently conducted what we understand is the first national survey of low-income renters and medical professionals that serve those low-income renters. It was a representative national survey. We talked to 500 medical professionals. These were physicians, nurses, nurse practitioners, PAs, and so forth. And we talked to about 1,000 distributive sample of 1,000 low-income renters in this country. 83% of the renters that we talked to told us that they will prioritize paying their rent to keep a roof over their head and their family's head before prioritizing anything else that is on their list of quote-unquote social needs. So when we have this discussion around the difference between social determinants and social needs and the movement that's occurring right now in healthcare to really better understand the social needs of panels, members, patients, populations of patients, we're getting a lot of momentum in sort of comprehensive social needs screening tools, right? Which is generally, a good thing. Nurses, techs, primary care physicians, so on and so forth, are asking these questions of the patients that they're seeing. They're asking them about food insecurity. They're asking them about housing issues. They're asking them about, domestic violence, safety, trauma, these sorts of things. And that's a wonderful thing. But when we have 83% of the folks that we're surveying telling us that they'll prioritize spending, paying rent before anything else, when they do go to the doctor's office, for instance, and they have to fill out this social needs screening, they've already paid their rent, right? So what's next in line in terms of, what those social needs are? It may be something completely different than housing insecurity or housing affordability. So I want to point that out in sort of conflating these issues and not understanding the interdependence between these issues. Because trade-offs are real, right? We have a number of folks in this country, unfortunately, who are making trade-offs every single day, choosing between whether or not to fill a prescription or to buy, the extra, fruit and vegetables when it comes to time to grocery shop, or to, spend the couple $100 on the new laptop that your child might benefit from when they're going from middle school into high school or something like that. These things add up. They're cumulative over time. And one of the risks that we face within this, the points that Alan was raising earlier, is misconstruing not only the interdependence, but an inherent sort of mental model that automatically leads us to all of these things adding up, summing up to 100% of population health outcomes, right? When that is never the case. We live in a dynamic relationship with many of these social needs, many of these social determinants, and at any given point in time, our relationship with those different needs, those different determinants, may place a priority on one thing over the other, kind of mismanaging that summing to 100%, so to speak. In that same survey, we had 100%, every single one of the medical healthcare, the healthcare providers that we talked to told us at least 15% of their current patient panel. Now, there's variation above that 15%, but at least 15% of the patients that they're currently seeing have told them, whether it's through a social needs screening or just in history conversation that they're gathering from folks, that housing insecurity, affordability, housing quality issues is something that they have to deal with and they feel like are impacting their health and well-being. That's an incredible number. This is a random sample of 1,000 renters, same with the medical professionals, 500 of them. And 100% of these medical professionals are telling us this. This is also placed in a context, a historical context, as well as a current lived experience context, where we have a growing trajectory, as I mentioned earlier, of physician, of healthcare provider burnout, which could be attributed, and this is why I think it's so important that Alan's journal, Health Affairs, is focusing on these issues related to housing and the social determinants of health, because we have people in the medical profession who go into the medical profession to be helpers, to be carers. It's a calling. I don't doubt that. I spent 15 years in the healthcare sector before coming to Enterprise, worked with many number of very dedicated, talented physicians, nurse practitioners, social workers, so on and so forth. They're there to help. And when they are faced with a majority, a significant number of the patients that they're dealing with telling them that they have to face, mold issues in their home, safety issues in their community, not being able to pay their rent because they got, the second job that they had, maybe driving for Uber or Lyft or something like that, wasn't, adding up to their, to meeting the needs with the rent burden that they're facing. What is that? What is left for that physician to do, right? If you're driven to help people, and now you're faced in the medical setting with an issue that you feel like you can't help with, what does that create? It creates alienation, it creates burnout, it creates despair, right? And this is a growing issue. Along those same lines, we have 89% of these renters that we talk to telling us that financial insecurity and the strain associated with meeting their financial needs every month is the single most important driver of mental health and behavioral health issues in their lives. Okay, this is in the context, again, of a United States where the 400 richest Americans own more wealth than the bottom 60% of the entire population. Okay? So where does this leave us? Well, we're going to hear more about the racial wealth gap and how that is tied to historical injustices, racial inequality, racism, policy decisions that systematically excluded people from attaining that opportunity to control their own destiny, having that security that Alan referred to, knowing that you have that cushion, that you have that asset, that set of assets to rely on to get you through this phase of your life or the next day or the next few years or a new childbirth or whatever it might be. I want to sort of close out these discussions with a little exercise, and I want you to forgive me. But I want us to think about two things. One, the fact that we're having this discussion today, the fact that this is becoming a priority not only in the healthcare sector, but it's becoming a discussion on the national stage. We have presidential candidates for the first time in my recollection actually talking about affordable housing issues, putting the inequality issues front and center in our collective health and well-being conversations. We have city governments, state and local governments trying to figure out how to address what has oftentimes been termed as an affordable housing crisis, again, in the context of trade-offs and priorities that they're facing from a budgetary standpoint? Do we put more money towards addressing opioid dependence? Do we put more money towards addressing people's health, mental health and well-being and behavioral health and well-being? Do we put more money towards early childhood education? All of these things, which are incredibly important. But I want us to recognize one particular issue, and this is why I'm asking you to participate. First, the word inequity means something, right? It doesn't mean disparity. It doesn't even necessarily mean inequality. It means an unfair and unjust result of decisions that were made by people who have the power to control the destiny of other people, okay? And that is incredibly important in reflecting on some of Alan's comments around why it's important for the healthcare sector to be looking at these issues today. Because it brings into full contrast the history, the current situation, and it also informs our future and the choices that we make collectively and individually in addressing these issues. So I want us to take just the last couple of minutes of my time on the stage today. I want you to close your eyes, take a deep breath. I know many of you probably did yoga already this morning or something like that. We're not going to do that. We're not going to do yoga again. I want you to close your eyes, and I want you to imagine in your head, I want you to think about and imagine a world, perhaps different than the world today, but a world that you feel proud of, that you feel committed to, that you feel blessed to be a part of. And I want you to imagine what it would take to get us there. And as you're thinking about this, the reason I'm asking you to do this is because the thing that's most often missing from discussions around how to address crises is longing, is vision, is an imaginary reconstruction of our social relations and our society that allows us to hold on to something that gives us hope. All of you on a day-to-day basis are working on resource allocation, you're working on implementation, you're scrambling to find money to do the work that you need to do. Oftentimes that money is short-lived, comes in small chunks, not enough to do the work. Many of you are competing with one another in an ecosystem of scarce resources. What would a world look like to you if instead of unnecessary competition, we were able to foster radical cooperation in addressing these issues? Because that radical cooperation, and I use the term radical, intentionally, purposefully, because the policies, the decisions, the structures that were put in place that got us here in the first place, I think we can all agree that those decisions, those policies, those structures were incredibly radical as well. And we're only going to correct that issue if we approach solutions with that same level of radical intent, perhaps in the opposite direction. And I'll leave it there. Thank you for your time. I really appreciate it.